oral hypoglycemic agents. Now, this is our objectives. First is to learn more about oral hypoglycemic agents. Then second is to be familiar with sulphonyl ureas, BIGUANIDES, MEGLITIDINE analogs, THIAZOLIDINEDIONES, and GLUCOSIDASE inhibitors. So first, we are going to discuss the sulphonyl ureas. These are hypoglycemic medicines that were initially launched as oral hypoglycemics. Sulfonamides are divided into two categories: first generation sulphonyl ureas and second generation sulphonyl ureas. Tolbutamide, chloropropamide, acetohexamide, and tolazonide are examples of the first generation, while glibenclamide, glipizide, and gliclazide belongs to the second generation. Sulphonyl ureas reduce ATP-dependent potassium channels in the plasma membrane of pancreatic beta cells. Depolarization occurs as a consequence and insulin is released. The presence of at least 30% functioning beta cells is required for sulphonyl ureas to work. This class of medication is frequently used in conjunction with metformin. They bind to plasma proteins and are metabolized by the liver before being eliminated by the kidney. They have the ability to pass the placenta and should be taken before a meal. Hypoglycemia, GIT effects, rash, and weight gain are some of the side effects. There is a link between NSAIDs and sulfonamides, making hypoglycemia more likely. They will cause severe hypoglycemia if combined with alcohol. Now, let's discuss the biguanides. Penformin and metformin belong to this category. They do not activate pancreatic beta cells and induce little or no hypoglycemia in non-diabetic patients. Insulin must be present in order for them to function. They inhibit hepatic gluconeogenesis and glucose production, improve insulin receptor binding, and increase insulin-mediated glucose elimination. They may reduce glucose absorption by increasing glucose uptake into skeletal muscle. The kidneys eliminate this class of medicines because they have a short half-life. Hypoglycemia, nausea, vomiting, and diarrhea are some of the side effects. Now, let's discuss the meglitidine analogs. By increasing the release of insulin from the pancreas, repaglinide reduces blood glucose levels. It accomplishes this by blocking ATP-dependent potassium channels in the beta cell membrane. This depolarizes the beta cells, which then open their calcium channels, causing insulin production to be induced. For example, repaglinide. Now, let's jump into thiazolidine ions. This acts as an insulator synthesizer by attaching to the peroxisome proliferator activated receptors in fat cells and increasing their insulin sensitivity. One example of this is rosglitazone. And lastly, the alpha-glucosidase inhibitors. It's a starch blocker that stops alpha-glucosidase from releasing glucose from bigger carbs in the intestine. One example of these are Acadz.